This interview, I'll say some things that'll either encourage you or trigger you. Being carnivore for 16 months hasn't reversed all the damage that's been done. My whole front wall of my heart was completely paralyzed. I can have a stroke. I can have a heart attack. I'm going to die someday.
Now, without further ado, let me invite back Dr. Phil Smith and Coach Raymond Nazon.
Hi, thanks for having me back, Bella and Raymond. I am today going to share some screens as I talk through. I'd help update on my health. What I want to do is to give an update on my personal heart journey, use it as an example of how one in the carnivore community might use it to learn how to assess your risk benefits of treatments that your doctor or doctors may be recommending to you for long-term health, how you go about decision making. And this interview, I'll say some things that will either encourage you or trigger you. So it'll be interesting to see what the community chat comments will be after this gets posted. And I want to reiterate that this interview is very personal and informational and not intended to direct anyone else's decision making for their health decisions. So it's more of a framework of how I go about it. And this is going to be very personal to my health, and no one should extrapolate any decisions, but I think I'll be sharing some information that may make you wonder, does this apply to me or not? And I'm going to be going over a couple peer review articles to help you with that determination. So a little bit about me, for those who don't know, I am a retired board certified family physician. Retired in 2019. I had a subspecialty of clinical informatics, which means I'm a little bit of a nerd, and I have a master's of science in biological sciences in physiology. So I like to use all that information to integrate science, medical information, and physiology, and trying to explain really difficult concepts to people. So I'm hoping that Bella and Raymond today will help me to clarify anything so that the general public will benefit from what I'm doing. I'm going to share my specific health findings with full transparency after being a carnivore for almost 16 months. I'm going to try to put some very difficult, complex cardiovascular concepts into understandable language that lay people can appreciate and understand. And in this process, I should be able to demonstrate how one goes through a personal risk benefit analysis when your doctor says, here's what you got, here's your options on what you should consider to do next. So as a little background, I did a prior interview with Raymond and Bella where I talked about the fact that I had a viral myocarditis in 2001, which led to a marked impairment of my left ventricular function, or the main part of my heart. My whole front wall of my heart was completely paralyzed. And I was put on two medications, a beta blocker and a ACE inhibitor. And after 2 years, my cardiomyopathy, or weakness of my heart muscle, did improve to where I retained all normal function of my heart, although I did have a little bit of leakiness of a couple of the valves. And in 2019, in November, I ended up having to need a dual chamber pacemaker inserted for a condition called sick sinus syndrome. When you have a infection, especially affecting the front wall of your heart, you sometimes have conduction abnormalities of the electrical system of your heart. And my heart rate dropped to 26 beats per minute, which was down from my normal of 44 a minute, and it just wasn't sustainable. So I have a pacemaker that if my heart falls down to less than 46, it will kick in and beat for me at 45 beats per minute. Since 2001, I have had 4 bouts of what we call paroxysmal or irregular atrial fibrillation, a total of 4 times. The longest those have lasted is 2.5 hours. And I have elected not to go on permanent blood thinners or anticoagulation because my risk benefit ratio is that my risk per year of stroke or major bleed from the blood thinner would be 7%, and my risk of a stroke without the blood thinner, knowing that I've never had atrial fibrillation longer than 2.5 hours, the literature says my risk is about 1% a year. So I do have a small risk of stroke every year of my life, but I've elected not to go on the standard treatment of blood thinners routinely for the purpose of doing risk analysis. And that's not what I'm going to be talking about specifically today. But when you're faced with something that is a 1% risk of stroke and the treatment is a 7% risk of stroke, that means the risk of treatment is 7 times the risk of not doing anything. So either way, I'm going to have a risk of stroke, and that could happen at any time. But there's a 99% chance I won't have a stroke per year. So I prefer to go with those odds. So that's how I made that decision. So my doctor, my cardiologist, wanted to give me a special drug called a antiarrhythmic drug that I could have on hand should I go into atrial fibrillation again after my August episode. And so in order to do that, we had to go through an evaluation to make sure I didn't have any silent coronary artery disease or any plaque in my arteries. So my last stress test and cardiac catheterization was back in 2019 when I had my pacemaker inserted. And so we did what's called a thallium stress test, which is where you inject a dye into the veins and do a stress test, and it's imaging of the heart. And there was a defect in an area of my heart called the interventricular septum, which could be due to the pacemaker wires, which are up against it, or it could be due to a blockage in one of my arteries that feeds that part of the heart. And so with not knowing which one it was and not being able to prescribe this rescue medicine, we decided jointly that I would go ahead and do another cardiac catheterization 2 weeks ago. And we're going to be discussing the results of that cardiac catheterization and what came up and how that compared to my prior cardiac catheterization. So cardiac catheterization is where they go up through an artery, they squirt dye into your coronary arteries off of your aorta, and they visualize using radiological images to visualize the lumen or opening of your arteries and see if there's any blockages. So that's what I had done approximately 2 weeks and 3 days ago on October 28th. Now, it's interesting to note for those who don't know me that prior to carnivore, I had metabolic syndrome with high triglycerides, low HDL cholesterol, and low LDL cholesterol, as well as a abdominal girth, waist that was more than 40 inches and was in the obese category for about 4 years. I went carnivore on August 3rd of 2023 and totally reversed all my markers for metabolic syndrome. 4 months later, I normalized my HDL. By raising it, I lowered my triglycerides, but my LDL cholesterol did increase due to the fat adaptation after 4 months, with my total cholesterol, which had been 180 prior to carnivore, with an LDL of about 80. My total cholesterol went to 311, with my LDL jumping up to 272. But my HDL was over 50 and my triglycerides were 68. So not too worried about those numbers, but I did have metabolic syndrome for probably 4 years now that I went back and looked at all my records and lab tests. Even though I wasn't told I had metabolic syndrome, the clues were there. No one ever connected the dots and made the diagnosis. So
were you diabetic?
I was never diabetic.
Okay.
Nope. So I'm going to share the results of my catheterization. So when you look at a cardiac catheterization, this is your right coronary artery, which fills off of the aorta, comes down the right and underneath the heart and feeds the right ventricle and the right atrium. Over here is off the aorta is your left main coronary artery, which is not as long as it's shown in this diagram, but this is cartoon is kind of showing it much longer than it really is. And it bifurcates from the left main coronary artery into what's called the left anterior descending artery and what's called the circumflex artery, which wraps around the back of your heart. So this feeds your front of your heart, where I had my cardiomyopathy, most damage from that. And this feeds the back of my heart and this and the side, the lateral wall of the heart. And there's a little branch off of the left anterior descending called the diagonal branch of the left anterior descending. And I actually had a blockage there. There was a little plaque there in 2018, but that plaque has now grown to 70% blockage. And it's significant because it's right at the branch. And so it's not in an area that you can put a stent or do an angioplasty, because the cardiologist said if he did, it would likely, if the stent clotted off or if the stent was misplaced by a couple millimeters, it would actually occlude my left anterior descending and give me a massive heart attack and actually increase my risk of a heart attack. So he felt it was best to leave this alone and to do other indications. Also, as the dye left my heart with each heartbeat, there was slowness of the dye clearing my heart muscle, indicating that I had small vessel disease, which is called slow runoff. And reviewing that and comparing it to the 2018 study, he saw that slow runoff was there in 2018. He thought at the time it was mainly due to my slow heartbeat of 45 beats per minute. But now that he's seen the two together, he realized that this indeed was small vessel disease that was there. Also, in the past month, I have had a sleep study which shows that I have central sleep apnea, which is most likely to small vessel disease of my thalamus, which is part of my brainstem that controls my breathing. So that's an part of your involuntary nervous system, which keeps you breathing at night when you sleep. So it's different than obstructive sleep apnea with snoring and what most people know. So it looks like the metabolic syndrome that I had as far back as 18 was causing the small vessel disease, which I did not know I had, but now I have it and I've got to deal with the consequences. Okay. So any questions about that?
So this branch that you have, so nothing was done with that diagonal branch for you then?
Correct. He just left it alone.
So that still poses a risk.
It poses a risk. And it's much like I told you with the blood thinner. I've got a risk if I do nothing. I got a bigger risk if I do something.
I see.
Okay, so I'm faced with something that could be a problem, may not be a problem, but we don't know when that 70% blockage occurred. It could have occurred and developed over the last 5 years, last 6 years since my last cath, or it could be something more acute. I'm very doubtful that my cholesterol being high for the last 8 months plays a role, but I can't rule that out either. But with all the small vessel disease that we found, it seems like most of this is due to the metabolic syndrome, which is why I went on carnivore and I reversed that in a matter of 4 months.
Reversal of metabolic syndrome helps with the small vessels of the heart?
Small vessel disease is usually due to thickening of the what we call the arterioles. So you have the aorta, then off the aorta you have arteries, And then the arteries branch down to these very small things called arterioles. And in metabolic syndrome, they tend to get thicker walls. So you have more resistance for the blood to flow through. And so that's typically small vessel disease is most often associated with diabetes and with metabolic syndrome, or with very severe forms of hypertension. But I am not hypertensive, so mine would be due, and I'm not diabetic, so mine would be due most likely to metabolic syndrome. And that's a different mechanism than a single plaque that I have in my diagonal artery. So implications for this then is I have a single lesion that could occlude at any time and would cause me an immediate heart attack or myocardial infarction. The lesion, when somebody has a heart attack, one of the first things they do is take you to the cath lab and try to balloon it or put a stent in. But the location of the lesion means the risk of that causing further problems is actually pretty great. So I really don't want to be in that situation because it's likely to cause more harm. And my small vessel disease runs me at risk to have what's called a silent heart attack, which, because the areas are based on the smaller vessels, people can have heart attacks in their sleep, have heart attacks and not know it. They usually don't have the crushing chest pain that you would have when the large vessel occludes. It's just that pieces of your myocardium or heart muscle can just die spontaneously, and you won't even know it until it's enough of it is gone that you get into congestive heart failure, or it's picked up on an EKG with some electrical changes. First thing I want to do is share this article. So this is a peer review article that was a collaboration with doctors in China, Iran, and Australia, where they looked at studies on what causes your arteries of your heart to get disease in the first place. A lot of people are wondering why statins are used so often, and it's because there's a mechanism of your LDL cholesterol becoming oxidized, and I'm going to go over that a little bit, and damaging the endothelium, which is the inner lining of your arteries. So an artery has three components: the inside, which is called the endothelium, the outside, which is the vessel wall that you can anatomically see if you're doing surgery on the person, and then the muscle layer or intima, which is the layer between the inner and outer wall. And I'll show you a diagram in a moment. But it's interesting in this large peer review study here, which reviewed a lot of articles that just came out in June of 2 years ago. Their very first statement is atherosclerosis, or blockages in your arteries, is an immune metabolic disease involving chronic inflammation, oxidative stress, epigenetics, and metabolic dysfunction. So in the carnivore community, we should take this to heart, because our carnivore way of eating is really targeting chronic inflammation, oxidative stress, and metabolic dysfunction. The genetics really is your family predisposition, which is an immutable thing that you're born with, that you're not going to be able to change no matter what you do. And there are some families that just have premature atherosclerosis. And those would be people that have documented atherosclerotic heart disease in their 40s, usually before age 50. So having a parent who has a heart attack at 80 or 90, that's not an epigenetic problem. That's actually pretty good genes, because that's a pretty long life. So when I'm talking about genetic factors for atherosclerosis, I'm talking about genetic factors for premature or early atherosclerotic disease in your 30s or 40s, or maybe even up to your early 50s. But you see that in the carnivore way of eating, we are attacking chronic inflammation, oxidative stress, and metabolic dysfunction. So if you look at oxygenated LDL on this diagram on the right, you'll see that the inflammation is mediated through damage to the endothelium or lining of the artery wall through activation of our platelets, which are small little cell fragments made in your bone marrow that clump together and can cause what's known as a thrombus or a clot, and macrophage dysfunction. Macrophages are white blood cells that are scavengers that are looking for external invaders that have gotten into your body or damaged areas, and they go in and attack that and try to chew it up. And then vasomotor dysfunction, which means you've got a problem with those little muscles I talked about in the arterioles where they have too much tone, and then autoimmune disorders that can predispose this to you. So if you look at plaques in a cross section and you cut across the plaque, obviously this is the inside is the endothelium, this is the intima level, and this is the external level, which is the vessel wall. And you can see the beginning of a plaque, and you can grade plaques based on their size and their composition, which is what they're made of. And you see initial fatty streaks, which may be due to damage of the endothelium and LDL cholesterol actually depositing to serve as a patch to the damaged endothelium. And it's not the LDL causing the problem, it's the LDL that's actually patching the damage. And but you start to see when you have a damaged endothelium that macrophages will start coming in, that releases chemical reactions, and then you get that patching thing. And as these grow, these lesions can further narrow the diameter of your blood vessel wall, and this is arteries, and you see that you get these very thick walled plaques that occur, and they get under the intima and actually can get walls of themselves, calcification, which is indicated by the white dots here, and more white cells and lipid cores that come in. And then the damage is, if this plaque ruptures, it can activate your platelets to come in and cause what we call an acute thrombus, or a sudden clotting of the clot, which further compromises the blood flow, if not clotting off completely the blood vessel so that no blood is getting through the artery. So this is kind of the progression when we're talking about plaque in our arteries. So when we look at this oxidation of LDL, there's all these enzymatic processes that occur, including reactive oxygen species. And reactive oxygen species are most active when we do aerobic type of activity, such as jogging. And that's why carnivores do better at tackling their adipose fat with sprinting and high intensity exercise rather than low intensity exercise, such as sprinting. So because that increases your reactive oxygen species when you're doing prolonged low intensity aerobic exercise, not walking, but doing more of jogging. And that leads to more oxidized LDL, damage to your myocardium. There's an enzyme in the mitochondrium called myeloperoxidase, which is a pretty new marker being measured in the drug, in the bloodstream in people. Not everyone's doing yet. And then there's the C-reactive protein, which isn't on this diagram. And you begin to have uncoupling of the nitrous oxide system. Nitrous oxide is a gas that builds up around the artery and actually vasodilates. And so when your nitrous oxide levels drop at the cellular level, you have less dilatation or dilation of the artery, and that leads to more constriction or less blood flow. If you look at the cross section of my artery on the right here, you can see what I would want all my arteries to be, and all my arteries are this way, but I have this 70% lesion, which means I have this huge plaque and only 30% of my artery at the beginning of my diagonal branch is available to get blood to the septum, which corresponds to the thallium stress test I have. So I am unable to take that antiarrhythmic drug for my atrial fibrillation. And I need to consider, how do I target getting more blood flow and getting this plaque to regress rather than progress. Progress would be getting bigger, and regress would be getting smaller. And I don't know whether or not this has progressed while eating the carnivore way of eating, or regressed or stayed the same, because I didn't have the catheterization proximal to me starting my carnivore journey, because my prior catheterization, where this lesion was a 30% lesion and pretty insignificant, going to 70, I don't know if that happened over 6 years or happened in the last 6 months, but my bets are it probably happened over the last 6 years. So this is kind of what I want to talk today. So on what's called targeting regression. And regression is, what do you do if you have an existing plaque? Can you reverse it? And what's the best strategy to reverse it? And this has actually been studied, and I'm going to share the largest review of 76 studies that have actually looked at this question. And we have found that there are 3 things that make a difference and promote regression of coronary artery plaque, or plaques anywhere in your body. First is to eliminate inflammation, and how best to do that. Second is exercise, how much and what kind. And the third is lipid management, and what strategy is best for me. So these are the 3 questions. And I'm going to go through this by using an article that was published also 2 years ago in the Journal of Cardiology. This diagram shows a fatty plaque in an artery. Raymond, I'm going to ask you, what percentage blockage do you think this cartoon shows? I'm going to put you on the spot.
50%.
Yep, perfect. So you could be an amateur cardiologist. So it shows pretty much a 50% blockage. So you see over here that in these studies, they specifically looked at reducing cholesterol, inflammation due to cholesterol, by giving a medication to damper the inflammatory response, and to give colchicine, which is a drug that we use to break gout attacks. So it's an anti-inflammatory that prevents cell division changes, and it's an acute treatment for gout. The other arms they looked at were using exercise, and specifically what type of exercise, to enhance repair of the lining or endothelium. And then the third, they looked at all these different types of strategies to medically see if they could impact the lipid profile in the person. And that included statins, as well as 3 other classes of agents. And then how do you monitor the person? And we now have some invasive and non-invasive ways of looking at arterial plaque. We can, these 3 over here are using devices that we literally do during a cardiac catheterization. We can now put a device down the coronary artery and essentially do intravascular ultrasound, which is what IVUS stands for. We can do high resolution visualization, and then we can do a semi-quantitative method of lipid measurement from within the plaque. And then we have 3 non-invasive methods, the first being coronary CT angiograms, which I'm going to show you a picture of in a minute. which is using just a contrast dye without putting a catheter in your artery, just putting contrast dye into your vein and then running you through a 256 slice high definition CT scanner and to take pictures of your heart and then do 3D reconstruction of your coronary arteries to define what type of plaque you have and the size of it in 3 dimensions. And then they're starting to test PET scan, which is positron emission tomography, but that's still in development and not currently available. And then they're looking at MRI also, but MRI has the limitations that MRI still has some issues dealing with a beating heart and synchronizing to the heartbeat. So you're trying to use magnets to look at a moving object. And then they're looking at other things like, should we be screening the population, more trials, and other ways to directly measure and follow people that were trying to regress their plaques. So this shows an example of a coronary angiography that is done, and you can see defining different types of plaque. This one's kind of bulging the wall of the artery. This was within the inner wall of the artery. This one's got calcium in it. This one has calcium in it. So you can see that we get incredibly good detail with CT angiography without using a lot of dye and without having to put a wire and a catheter into the person's artery in the cath lab. We can do this in the radiology suite. It's not currently covered by a lot of insurance companies or Medicare, so you often have to pay for it out of pocket, but to prevent unnecessary returns to the cath lab, it's worth it. And then this shows these 4 methods of looking at plaque. The IVUS is putting the ultrasound down, and you can actually see the opening of the lumen and the plaque, and then using different frequencies, either colorized or non-colorized wave. And then this, as you can see, it gives you a pretty good picture of how big the lining of the heart is. And Bella, that last one was a 50% lesion. What would you say this one is? So this is the opening, this is the plaque.
Sorry about that. So the lesion is how much plaque has built up?
What percent is the green as opposed to the black?
I would say that's 60 to 70.
Yeah, that's pretty good. 60 to 70. Probably, if I look at this slice, it's probably closer to 60. 60 to 70 is a good call on that. So that's going to be pretty similar to what I have right now, even though we did not do an IVUS test. I know how I'm tackling inflammation, and I'm doing that totally from diet. But what do all these articles, these 76 articles say? And how do I put those in there? And essentially, what is the role of statins in secondary prevention? In the carnivore community, the general dogma is the risk-benefit ratio is not favorable just for generally taking them because your LDL is cholesterol. LDL cholesterol is not the main culprit, but I don't have one main culprit. I think my culprit was metabolic syndrome, which I've addressed, but now I have to reverse the damage done already. And so I'm not focused on my lipid levels. I'm more focused on reversing disease that I've earned through my metabolic syndrome in a dark way. So when we think about statins, most people think of it as a drug to lower your LDL cholesterol. It's a HMG-CoA reductase inhibitor working through a specific enzyme in your liver to turn off the production of LDL cholesterol in favor of the other non-LDL cholesterols. But there are also several what we call pleiotropic effects of statins. And pleiotropic implies that they're not what the FDA approved the drug for, but there are benefits that have now been discovered through the hundreds of studies that have been done that weren't initially expected, and they're not related to their LDL lowering effect. They're independent of the LDL lowering effects. And it's interesting, my cardiologist doesn't have high LDL, doesn't have coronary disease, and he's taking a statin every day for the pleomorphic effects, for preventive health. I'm dealing with a true believer, which I have to have discussions with. So don't think my cardiologist is a pushover when it comes to difficult, crucial conversations. He would probably put it in the water supply if he could. So, but he's a very smart guy, and we're always discussing the literature. And that's why I see him as a true partner. And we come up with some very unique treatment plans for my situation, which sometimes may not be what the typical person's going to get from their doctor.
If you're experiencing symptoms like lower energy than usual, headaches, or muscle cramping, these are telltale signs of electrolyte imbalance. What you can do is just salt all of your carnivore meals a little bit more generously, and of course, use the high-quality salt as opposed to table salt. If that doesn't do the trick, you can also lean on a very high-quality electrolyte supplement. This is the one that I personally recommend. It is from the brand Element, spelled out LMNT, and specifically this blue colored box labeled raw unflavored. I like this one because it is unflavored. There's no stevia, no flavorings, sodium, potassium, and magnesium measured out for us in the right quantities. This is what each of the little packets look like. They're very small and handy to pack on the go. Throw it in your gym bag if you work out a lot. Throw it in your travel bag, work bag. You just rip one open, pour it in whatever you're drinking, mix it up, drink it down, and you're good to go. You all can get a free sample pack like this, and it does include the raw unflavored version with any purchase. If you go to the URL shown on the screen, drinklmnt.com/SBGAL. Also link them down below.
But these pleomorphic effects, and I talked about the pathogenesis or the things that go wrong with your artery. So let's talk about things that statins do that are pleiotropic. First off, they improve the endothelial function and create a protective effect by stabilizing the lining, the internal lining of your artery, the endothelium, in both your brain and your heart. And that's really critical for me because I have this small vessel disease in both my brain and my heart, and I'm trying to reverse that, and certainly don't want it to get any worse. And that pleiotropic effect is due to the effect of nitrous oxide building up in the intima and providing some vasodilatation or enlargement or relaxing of the muscle that wants to constrict that artery so more blood flow can go through. Secondly, there's a response of reducing the inflammation in the wall of the artery, and we see that measurable with a reduction in the highly sensitive C-reactive protein test or HSCRP test that you may have done if you have heart disease. And it's been shown that people with this inflammatory marker are more prone to have heart attacks. And so it's a good thing to measure. And my CRP since going carnivore is normal. So I know that endothelial inflammatory response is no longer an issue. There seems to be a benefit of re-endothelialization, which means actual creation of new endothelial cells growing over and repairing breaks into endothelium so that we're actually regenerating a healthier, intact wall of the artery. And also vasculogenesis means the formation of new branches of your arteries so that you're doing what we call collateralization or creating new pathways of blood in your heart and brain so that you're not relying on only the existing big vessels, but you have a network of small vessels as well. So this re-endothelialization brings in new vessels, repairs the existing damage, and can give you more ability to tolerate stresses and less worry about having that acute heart attack that you might have otherwise. Endothelial fibrinolysis is actually, as those macrophages come in and try to attack that plaque, you can get the side effect of fibrin depositing. Fibrin is a scarring mechanism that occurs. And if you've ever had a cut on your hand that got infected and you see a scar that you have for years and years, that's mostly a fibrin scar that forms because the white blood cells, in fighting an infection and trying to heal you, have gone overboard, and there's been fibrin deposition, which is kind of a rubbery substance. And when your inside of your artery gets fibrinized, it actually becomes stiff, like rubbery. So again, it can't dilate as well, and it can't function as well. And then plaque stabilization, meaning the plaque is less likely to grow and to rupture. So these are all what we call pleiotropic effects. The one that was not from this article, but I know from another article, is people that have had multiple heart attacks and develop congestive heart failure, which we call ischemic cardiomyopathy, basically meaning lack of oxygen has caused your heart muscle to fail. They actually have improved regeneration of the heart muscle itself, what we call remodeling, as a result of a pleiotropic effect. But that was not addressed in this article on endothelial repair. I want to go across this study because this study, which should give us like definitive answers to what we should do for regression, and they looked at achieved LDL cholesterol based on the intervention they did. And they looked in change in plaque volume. Going down is good, which means the plaque is shrinking. Going up would be bad. So we had treatments where they actually got worse. We had some where they really got better, but it wasn't it didn't, this index of 1 would be no change to your LDL. This would actually be an increase in LDL. And you can see that irrespective of the LDL level, you can get improvement. And the studies use different means and materials to determine that. So I'm going to go over those because I want you guys to know that just because it's in the peer review literature, these studies don't mean they're all saying the same thing, which makes it very confusing and why you have to kind of do your research yourself sometimes to find out what you're actually looking at. And so I went through these 76 studies and kind of summarized. And I have a lot of abbreviations over here so that you can see what they mean. Statins, I think most people know, very common. A lot of people have experience with them. They work by a liver pathway to reduce LDL cholesterol production. Extimidamide slows the absorption of dietary cholesterol, so it works in the gut so that you don't absorb dietary cholesterol. That's different than shutting down cholesterol being made by your liver. The PCSK9 inhibitors are extremely expensive, thousands and thousands of dollars. They're injected once or twice a month. And what they do is they bind to this enzyme PCSK9, which attaches to the LDL receptors and then removes the LDL. So the first one slows down production of LDL. This one slows your dietary absorption of LDL. This one literally removes LDL from your body. And then we have this other one, cholesterol ester transfer protein, which increases your HDL and lowers LDL. But unfortunately, when you use it, your risk of dying is higher. So probably not a good choice if you're not wanting to die. And then the last one is EPA, which is a type of omega-3 fatty acid, which reduces triglycerides and improves cholesterol levels. So it's like supercharged fish oil, which is given as a prescription.
Okay,
Sure.
so technically with what you're saying, with all these LDL part, technically your blood work beforehand when you had low LDL and then low, well, probably not low HDL would be a good thing, but wouldn't that have been ideal where you wanted to be with the low LDL technically back then?
Yeah, not with metabolic syndrome, because the metabolic syndrome contributes 600% increased risk of atherosclerosis in the heart. Well, where the best contribution of LDL in and of itself without metabolic syndrome, without smoking, without obesity, would be contributing maybe 2% a year. So 600% versus 2% would be 300 times more risk. And that's why when people like Dr. Ovadia says he does bypass surgery, half of the patients have normal LDLs and half have elevated LDLs, and why more and more studies are showing the LDL itself is a marker of using the drug, but it's not necessarily a marker of atherosclerotic stimulus in your arteries. So we have to rethink that. There's a lot of ongoing research. So that's why I have to throw out not worrying about what the LDL actually is, but can I manipulate the LDL to cause plaque regression, regardless of, and not worry about what the LDL level is, because the studies showed benefits regardless of what you did to the LDL. So that's the important thing to get from that last chart, which is the scatter diagram of the 76 studies, which is all over the place, saying there was no consistent findings. And what I'm doing is breaking down in groups what each group of studies were looking at and how they performed on actually regressing plaque through these non-invasive methods. So they did these studies. Most of them were 10 to 20 months. And they measured either using one of these techniques. They measured them before, they measured them after, and determined what happened to their plaques. Did they get bigger? Did they stay the same? Did they get smaller? And did they meet the test of randomization? Was it significant enough that you say it's due to the study, or is it due to chance?
And was there any mention of death on any of these studies?
Yeah, these weren't really about outcome studies. These were the people that survived for the length of the study and were able to be tested before and after. So interesting with lifestyle intervention, and there was no really dietary arm in here. And as I said, reducing inflammation is by far the most important thing we do. And we do that with our carnivore way of eating. So keep that in mind. But they did look at lifestyle intervention of various types of activity, such as aerobic activity like jogging or swimming, looking at stepping. And 2 out of the 4 actually showed significant regression of plaque. And the one that improved the best was 7,000 steps per day. So since I recovered from my catheterization, I've turned up my goal meter on my watch that measures my steps, and now I'm walking 7,000 steps a day.
Okay, let me get this right. So anything much more than 7,000 steps is not as good. So the medium is the best at 7,000 steps. Is that what I'm saying?
So basically going beyond that, it's not necessarily bad, but getting into jogging actually could increase your, I'll go back a couple slides, your reactive oxygen species increase right here, which is a major contributor to oxidizing your LDL. And so there's 2 things that I would want to avoid because of my lesion, which is I don't want to increase reactive oxygen species by pushing lots of aerobic exercise, so treadmill jogging on treadmill or running or anything. That doesn't mean I can't do sprinting, the Dr. O'Mara protocols. And I have cut out any resistance training with any heavy weights, because anything that increases my resistance, such as weight training, would actually increase my vascular resistance and would be a negative for my small vessel disease.
Fascinating.
So I've cut out weight training, and I will reintroduce, once I get my arm totally healed up, I will probably be doing some push-ups to limit every day, but maybe some very light hand weights, but I'm not going to be pushing resistant training because of the effect it would have on my small vessel disease, causing hypertrophy of the small vessels, which would further restrict the blood vessel. I wanted to go through this because these are the big studies, and we use statins for these pleomorphic things, but I want you to know how weak they really are. So they looked at people with just statins versus people without statins. And there were 16 studies done. Only 4 of them actually showed improvement in regressing the plaque. So most of them had no change, which may be significant that they didn't progress, but you can't tell because they're not significant. You don't know if that was a random effect. And some of them actually got worse. They had progression of their disease. And then they looked at high dose statins, 10 studies. 8 of those showed no benefit. So only 2 out of 10 or 20% showed benefit. So you're seeing the statin studies, out of 26 studies, only 6 showed improvement and the other 20 didn't show improvement. So I look at that and say, wow, that's only so strong. But in the ones that there were improvement, we're talking typically 5 to 8% regression over a period of the study. And the studies went from 12 months to 20 months. So the question is it too short of a time to see regression? But certainly I'm a little leery when some of the studies actually showed it getting worse. And then they use this exenatide, which is a dietary agent. Out of 7, only 1 showed improvement. The non-statin agent, which is very expensive, there were 2 of those. They didn't show improvement at all. None of them did. The one with the CETP inhibitor, only it showed improvement, and it was significant. But again, this is the mortality was higher in this group, so the dropout was higher. The next one is the omega-3 type, and 1/3 of them showed improvement. 5 were treating with blood pressure medicines to dilate the blood vessels. 4 of those showed no improvement. 1 did in the plaque itself. And remember, the endpoint is, did the plaque get bigger, smaller, or stay the same? Only 1 used colchicine to reduce inflammation. It didn't show any improvement. There were 3 using blood thinners. Using oral diabetic meds. And all 3 of those were significant, which we would think you're reversing, trying to improve insulin sensitivity. And those actually showed improvement. And we know in the carnivore community, we improve insulin sensitivity. So I found that as a very positive pro-carnivore study, these 3 studies that used oral diabetes agents. And then 14 of them just use miscellaneous things like testosterone supplements. And I wanted you to know that testosterone supplements actually was the worst thing you could do. The plaques progressed by 21%. It was the largest progression, which means they got worse compared to the 4 times worse than the placebo. And it was a significant study. So that's kind of scary for guys who are taking testosterone and have plaque. Probably not a good way to take it. You should be trying to change your testosterone level with your diet. So anyway, Bella, does this all make sense to you, that we have a lot of studies, a lot of data, but only marginal benefits, but there is some benefit in some studies. And it's really the best is the regular dose statins, which was 25% improved, versus the high dose statin, which had actually did worse than the low dose statin. So here's the consideration that I think we all need to have when we're considering things like that, is you need to know what you're actually treating, and not just throw statins at things because you think it's a good idea. But if you have something that you can measure and follow, that may be a benefit from you. If you have ischemic cardiomyopathy, it might be a benefit from you. But then you need to decide what are your goals and what would you say would be worth doing something to achieve better results. And I'm in this quandary. I don't know if my plaque has regressed, progressed, or stayed the same after 8 months post reversal of metabolic syndrome. So, and 16 months of as a carnivore, is it better now than it would have been had I not been carnivore? And then what is the best interval to reassess? Most of these studies say 12 months is too short. Most were done 12 to 20 months. So you got to put that into your calculator and figure out what you're going to do. And you need to know what the risk and benefits of your treatments are. You need a physician who will have honest conversation with you. And I call that making your physician your partner rather than your parent. It does no good to have a parent-child relationship and say, yes, daddy, I'll do whatever you tell me. You should take the time to have these conversations and say, what do you recommend? What would you do? And I always like to ask the question, if I was your brother, what would you recommend to me? I try to make it personal with my doctor, because I don't say, what would you do for yourself? Because they're always really biased with that question. And as I said, my cardiologist, I already know he takes a statin just because. So he's on the other extreme of thing. Okay. So in ending, here's what I decided to do. I decided that I'm going to continue my carnivore way of eating because I'm convinced it has totally reversed my metabolic syndrome. I know I've demonstrated with lab tests and markers. And so I have reduced my cardiac risk, which was 600% higher than normal. And I've totally eliminated that. I'm not worried about the LDL level at all, because that's an insignificant risk factor when you have a high HDL and a low triglyceride level. I have added 7,000 steps per day, which basically meant increasing by 2,000 steps a day. I have paused any weight training, and I'm going to ease back in and doing some very light range of motion exercises with low weights, not push it, and to do some push-ups once I recover fully from my catheterization. I'm going to go ahead and add a statin for 2 years. And I'm adding it not because I'm worried about my LDL cholesterol. I'm using it to see if I can reverse these pleiotropic, that's misspelled. It should be pleiotropic effects, not pleomorphic. My pleiotropic effects. And I'm going to do it for 2 years, get a baseline CT angiogram now, which I'm getting scheduled. And then I'm going to repeat that in 24 months with the goal of stopping my statin. And I've told my cardiologist, if my statin shows any harm to my liver, any muscle aches, or any return of insulin resistance, I, of course, will stop the statin. But if I'm tolerating it well, I will stay the course, do it for 24 years, and then report back to you all, because I think it'll be an interesting case study with an N of 1 to see what happens. And if I pass away in the interim, it was probably may or may not have been the right thing to do, but hopefully I'll be here to share my endpoints and go from there.
So 24 months.
24-month commitment.
Beautiful.
And so far I'm doing okay with the statin. So I haven't had any side effects, but I've not had any blood tests to reassess my liver. I'll probably do those in 3 months to make sure I'm not having ill effects on my insulin resistance. So anyway, that's
Thanks for
kind of
that.
how it's going. So I never thought I would see myself on a statin, because I don't think in the terms of managing an LDL number in a lab test. But these groups of studies that have all come out in the last 2 years in the peer-reviewed literature have been compelling enough for me that I'm just going ahead and bite the bullet, take the statin for 2 years. And there's no guarantee the statin's going to do anything. It may actually make it worse. But if I look at the 3 factors of activity, that is something I can do. Reducing inflammation, that's something I've already done. And so instead of ignoring the third arm, which is taking a lipid modifying medicine for its pleiotropic effects, I'm going to head and add that in and see where I'm at it 2 years from now.
Maybe some viewers are now watching this video thinking, oh my gosh, could Dr. Phil have gotten these results or have been put on a statins maybe because of his diet change going into carnivore diet, strict carnivore? Could that have contributed in any shape or form? And they're getting paranoid. What would you like to say?
Sure, absolutely. And I think that always goes through people's mind. For me, the studies very clearly show that the pleiotropic effects, which as a physiologist, I want to heal my endothelium. That is my goal. And for the average person, they don't even know what the endothelium is, right?
Right.
The lining. And so I'm using a medication for a very, very specific reason. And I really don't care what my LDL cholesterol is when I get it rechecked, whether it's normal or still high or higher. It makes, and some of these studies showed the LDL actually doubled. So again, I'm not adjusting or using the LDL, because if my LDL doubled and I worry about it, I would double the dose of the statin. And the studies show that that would be the worst thing to do, because you actually increase the risk of the plaque getting worse by doubling the statin, as opposed to staying in a fairly moderate to low dose statin. So these are the things you got to figure about. And the much bigger risk factor in this discussion of coronary artery disease, whether it's small vessel or a big vessel like my 170% plaque, is what are you doing to reduce the inflammation? As I said, you've got one risk factor that is a 600% or 6 times risk factor, which is your metabolic syndrome or diabetes. And then you have this other risk factor, which is a 1 to 2% risk factor. So the difference between worrying about your LDL versus worrying about your metabolic syndrome is 600 times greater with the metabolic syndrome. So people need to focus more on their metabolic health and less on their lab results, in my opinion. So I hope that answers the question.
Yes. Us 3 here, we've been in the carnivore community for a couple of years now, and I myself have seen like videos, stories, posts in communities just circulating about things that have happened during a carnivore experience. And because of these posts and videos, people outside of the carnivore community will take it and twist it or manipulate it in a way where they literally blame the carnivore diet for that experience or for that scenario. What do you want to make clear to people who are worried about those types of things?
Yeah, thank you. That's a great question. And I watched that video, influencer that had the stroke. And she tried to attribute it to the carnivore diet and then admitted that she had a defect in her heart. It was actually a venous thrombosis that went from her leg up through her heart and went to her brain, which I've seen before. It was totally unrelated to diet. But she cleared and improved considerably. And my question to her is, did you get better and not have any long-term side effects because you are a carnivore? But I think some people think that carnivore way of eating is a immunity gene or a immortality gene, and it's not. We are still going to have things that happen to us.
Yes.
And we all have the damage we've done for years and years and years to our bodies. And things happen. We have acute stressors. I had my cardiac catheterization on October 28th. I had a pretty rare complication. I got a blood clot in my radial artery in my wrist, which before I had a lot of pain and it seemed to be spasm in the artery. And it grew all the way to 8 inches by ultrasound. Now on a blood thinner for 90 days, which I don't like to take because I told you my risk of blood thinners is, but this is a reason you put on blood thinners in order to stop the blood clot from getting bigger, which it went from just being at my wrist and extending 8 inches. That's because it grew. So you put them on blood thinner not to dissolve the clot, but to keep the clot from growing and getting big. Now, an arterial blood clot's a little different than a venous blood clot. But if you think about it, it's clotting of a plaque in your artery that can cause a heart attack. So it's a similar thing. So did the carnivore diet put me at a higher risk of having a clot in my radial artery? So that's my own personal example. Well, as it turns out, this was my 4th cardiac cath. The first 2 I had in my right radial artery. And after 2, my right radial artery clotted off. And that was back, the first one was in 2001. And the second one was around 2010, long before I became carnivore in 2023. So I have reactivity in my radial artery, which causes me to clot it off. So when he did the catheterization in my left artery this time, he said I had an incredible amount of spasm. And he said, I see why your right one clotted off, because your artery doesn't like me sticking wires in it. And it reacted to it and went spastic. And that has nothing to do with diet. It's no different than it was pre-carnivore. It's just that carnivore didn't prevent it from happening, right? So if I'm going to play this game of blaming it on carnivore or blaming it happening or not happening, where do you fall? Because I can't blame this on carnivore. And it's a risk factor, known risk factor I've had because I've done it before. The carnivore didn't prevent me from getting it, but it doesn't mean the carnivore failed me. It just means that I have very spastic arteries when you start putting catheters up in them. And that's why I'm going to be going the non-invasive route to measure my heart function rather than the invasive routes in the future, because I don't want to go through this again. So there is no doubt that, well, I'm going to go back to the statin studies. When the statins first came out, they did studies mostly in Europe, and they were looking at all-cause mortality and people treating with statins versus placebo. And they found that there was an increased risk of death in people taking statins over not taking statins. So the statin group had an increased risk of death. But what they found in looking at the data, the reason they had an increased risk of death was because a couple people, one had auto accidents. One got run over by a tractor and the other one was in a car accident. And the groups were so small that 2 people dying from accidental deaths through the study, and actually often showed that the people on statin, that group, had a higher death rate than the people not on statins. Now, is that cause and effect? It's probably random chance, although you could say, well, the statins gave them brain fog and they forgot how to operate a tractor. I mean, you can make up a story and try to paint that. But the fact of the matter is, when we do these studies, it's sometimes hard to say cause and effect because they're observational studies and not double-blinded studies. So we have to keep that in mind. And I have to realize that my life has an expiration date on it. I'm going to die someday.
Yeah.
So the question is, what can I do to not speed that up so it comes earlier than I need to? And I'm going to do everything possible that I can do, but that doesn't mean I'm going to live forever. Stuff happens. I can have a stroke. I can have a heart attack because I did damage to my arteries long before I came carnivore. But from a physiologic standpoint, I know I'm metabolically healthy and statistically have drastically reduced my risk factors for atherosclerotic heart disease and stroke. But that doesn't mean I've healed my arteries after 6 or more years of being metabolically unhealthy. Being carnivore for 16 months hasn't reversed all the damage that's been done. So I still have risk factors and I should continue to moderate those. But it's hard to find an association when you have hundreds of thousands of people eating the carnivore way of eating and somebody has a stroke. Why do we jump that the stroke was caused by carnivore no more than I could say, jump and say the complication of my left radial artery was due to do carnivore. And I wouldn't have known that had I not clotted off my right radial artery. So I can conclusively say there was no association. It's an independent risk factor. So we have to, and until there are studies looking at hundreds of thousands of carnivores and following this out, we're not going to know that for a while, but no one's going to do a provocative study to try to prove, we're going to take 100,000 people and have them eat until they have a heart attack and have 100,000 people eat the standard American diet and wait and see how many have a heart attack and then compare those two groups. That's just not an ethical study that we can do.
Where can people find you? And how would you advise them to learn more about the topics that you've discussed?
You may be watching this 2 years from now, but I would really encourage you to come to Hack Your Health in Tampa in November of 2025, where we're going to have a panel, and it's called How to Be a Carnivore in a Non-Carnivore World. And I'm going to be specifically focusing my part of that panel on how to turn your doctor from your parent to your partner, because I think that's something that people don't know how to do. I'm not on any social networks. I don't have a YouTube channel, or I'm not on X or any of the social platforms. I got rid of those when I retired. And so I can be found on Bella's Steak and Butter Gang private network, and where I interact with people in the community all the time who ask me questions. And I try to take these complicated discussions on health and labs and motivation and things that I can address personally and try to give some clarity to the difficult concepts so people have more information so they can have meatier discussions with their physicians, their healthcare providers, and have a little less fear about the unknown.
Since January is World Carnivore Month, I will be celebrating the top of the new year and this amazing month with Dr. Sean Baker. He is coming to my community to celebrate World Carnivore Month with all of the members. I will also be bringing on Dr. Chafee, Dr. Robert Kiltz, Dr. Tony Hampton, Coach Rebecca Heischman, and dietitian Michelle Hearn. And you will have easy to follow weekly guides, meal plans, and recipes to ensure that January is the best month of carnivore eating for you. All you have to do to join us is go to the URL shown on the screen, sbgmeetup.com, or the clickable links are down below in the description box. See you in there. Thank you for watching the video, and I'll see you in the next one. SBG out.